Good evening, ladies and gentlemen, dames and here, bommeli bontate, manene nani manenekazi, banumzane namakhosikazi. My name is Dr. Fundi Lenyati. I'm your host on this Dr. Fundi channel tonight. Thank you for choosing to be with us on this webinar that promises to be quite interesting and useful. We have managed to get some of the best people to talk on the various aspects of the webinar. We've got Dr. Lebogang Patladira, who is a specialist psychiatrist and also a senior lecturer at University of Stellenbosch or Stellenbosch University, within the psychiatry department. So he is one of the best in what he does. We also have Miss Kosi Gianni, who is a qualified and experienced clinical psychologist, but she doesn't just do work within the space of clinical psychology, in terms of seeing patients. She does a lot of other work, on the media, radio, TV, hosting, co-hosting, content producing. So she's the second speaker. And between the two of them, we are honored to also have, the Speaker of the Council of Johannesburg, City of Johannesburg, Madame Noneba Mulwele. So she will speak between Dr. Patladira before we start with Ms. Kosigiani. And she'll just speak for about 10 to 15 minutes, just, giving us a view around issues of mental health from a community perspective. As the speaker of the biggest city in Africa, with a lot of townships of people who are quite disadvantaged, she's seen and experienced a lot of things around access to issues of mental health services. So she will briefly contextualize that. Now, I normally do what we call Speaker Wednesdays with her, and her role is that of civic education. So since we started these Speaker Wednesdays, we broadcast to the communities in and around Johannesburg. So she has therefore managed to also get community radio stations like Josie FM, like Alex FM, and Eldos FM also connecting, so that the message that will be shared in this webinar will go beyond the people who are within this webinar. So just hold on. Right, so that's basically how we're gonna do this thing. The first 20-30 minutes, we'll have Dr. Patladira, and then we'll have the speaker for about 10-15 minutes. Then we'll have Usis Kosigiani. So Dr. Patladira will have a presentation that is on PowerPoint to drive his presentation. And then, the speaker will just talk, and Siskosi will have a conversation. So just before Dr. Patladira, comes through, I just want to quote something from a professor of community psychiatry in King's College London, on an article that he wrote on the 9th of December last year. He said, Professor Sir Graham Thornycroft, he said, alongside the sometimes severe and fatal physical consequences of the SARS-CoV-2 virus, there is a threat far less often discussed: the mental health implications of COVID-19. The true breadth and depth of this silent epidemic is now only becoming clear That was Professor Sir Graham Thornycroft from Community Psychiatry at King's College in London. Then there's also a second one, just another quote, just to give context to today. W. Cullen and others writing in an article on International Journal of Medicine, he said, during any outbreak of an infectious disease, the population's psychological reactions play a critical role in shaping both the spread of the disease and the occurrence of emotional distress and social disorder during and after the outbreak. Despite this fact, sufficient resources are typically not provided to manage or attenuate pandemic's effects on mental health and well-being. While this might be understandable in the acute phase of an outbreak, when health systems prioritize testing, reducing transmission, and critical patient care, psychological and psychiatric needs should not be overlooked during any phase of the pandemic management. So I thought, let me just make those two quotes just to give a sense as to why we saw it fit that we should have this webinar that's focusing on mental health, well-being, and illness during this time of COVID-19 pandemic. So I will hand over to Dr. Lebogang Phatladira to take us through on our first presentation. Dr. Phatladira, over to you.
Thank you, Dr. Nyati, for the invitation. I think we are at a difficult time, all of us, and we would like to be meeting and engaging in a different way, in a hall full of people, sharing drinks, but we have to do it this way. But I also want to thank you for this kind of platforms that are more educational for not only people in the profession, but members of the public in general. So my talk will be on just, what essentially happens in the brain in people with COVID-19. The talk will not be in depth so that everybody can follow. I'm aware that not everybody who has joined is a medical professional. I have tried to simplify it so that people can follow. But for those who might want more information, I'm more than happy to share the references or to discuss anything further from our experiences in treating these patients, some of which I'll be talking about. And lastly, to say that what I'll be talking about is not exhaustive, and all these topics that I'll be talking about needs a presentation of their own. So not everything that I'll be talking about would be exhaustive. So we know that the SARS coronavirus 2 was identified in 2019 in a city in China, but this was identified to be more contagious compared to previously identified coronaviruses, with even a longer incubation period of up to 2 weeks. The WHO declared it a pandemic in March last year. It was only towards the last part of 2020 when neurological and psychiatric problems were being reported from various parts of the world. And also, this was supported by histological findings on postmortems, so findings on the brains of postmortems of patients who have died from coronavirus. So the virus enters the host cell, which is the human in this case, through the angiotensin converting enzymes. And what is important is that it has about 20 times more affinity to these receptors compared to other coronaviruses or any other form of medication that might have its mechanism linked to these receptors. Of importance is that these receptors are found in adipose tissue. For those not in medicine, adipose would be fat tissues. They are found in high concentration in the brain, in the heart, and also in the lining of the blood vessels. They are also found in the liver, and a lot of them also found in mucosa of the nose and the mouth. Of particular interest to psychiatrists is that these receptors are found also in parts of the areas of the brain that controls motor, but also parts of the brainstem. This is particularly significant, as you'll see later on in my talk, that you could have disruption of the brainstem. So brainstem would be parts of the brain that connect the bigger brain and the spinal cord. And this is where the respiratory center is. And some physicians maybe on the platform might confirm, but there are reports that some of the patients may present with respiratory dysfunction without necessarily having pathology in the lungs. And I'm emphasizing this point because there's this culture or fashion of steaming that many patients may actually, you might go into respiratory problems leading to respiratory failure, and finding that the problem is not necessarily in the lungs, and you delay treatment only to find that the problems has to do with what the virus is doing to the primary respiratory center, which is in the brain. And also it affects, the olfactory bulb is the nerve that helps us to smell, and also part of the brain which has to do with a movement, something called the substantia nigra. So this might be it's a bit of a complicated physiological slide, but those in medicine might be of interest. The point that I want to drive home is that the virus, unlike microorganisms like bacteria, it's not alive. So it doesn't have blood, it doesn't have a heart, it doesn't secrete anything. So what happens is there are multiple ways in which through which it affects the human body. But of particular importance is that it can cause direct destruction of the cells. But I think what more or less cause a poor outcome relates to what we call this the cytokine storm. So this is how your own body responds to the presence of the virus in your system. So I've also put in this slide just to drive one point home that so this is the cytokine storm. So this is what happens when what leads to many patients having a poor outcome, including death. But the point that I want to drive home here is that the cells that lead to the cytokine storm, which are macrophages around others, they have genetic predisposition. That is why not everybody who gets the coronavirus would get a cytokine storm. So I'm driving this point home to drive a message that if you have somebody in your genetic lineage who has had severe disease of severe COVID disease, and you are elderly and probably with some comorbidities, you probably should be on level 4, level 5, because it is more likely that you will experience the same. Besides the brain, the coronavirus, can cause a systemic illness, and if there is one message that I think everybody has to take home, is that it's much more than a respiratory illness. So, for example, it can cause, what we call deep vein thrombosis, so just blood clots. It can cause blood clots essentially anywhere in your body. So you can present with heart attack, you can get stroke, and so on. It can, as I say, it can present with heart problems. So it can lead to damage to some of the organs that are related to management of your sugar, particularly the pancreas, the autoimmune response. So when your body responds to the invasion of the virus in your system, you might lead those antibodies may be destructive to the pancreas, leading to new onset diabetes, poor control of those that already have diabetes, and so on. And kidney problems, you may, see these patients even without, they might have elevated liver enzymes, and we'll refer to this later when we talk about medication, that you need to be careful that even patients with mild and particularly those with severe illness would have elevated transaminases or may have elevated transaminases. And the GIT symptoms, nausea and diarrhea and vomiting, abdominal pains, these are some of the common presentations of this illness. So just briefly, maybe I think psychiatric registers, it might be important for them if they're on, they've joined, that, what happens is that so the neurons in the brain are connected to each other. And therefore, so between these connections, the virus can transfer from one neuron to the other, loosely speaking. But also, as I said, the virus affects the blood vessels everywhere in the body. So even the vascular lining in the brain can be infected by the virus. Also, there is what we call the blood-brain barrier. So the brain is very, very much protected from what happens from the rest of the body by what we call a barrier. So not everything, or toxins, or some bacteria and so on that affect your body, not everything gets to go to the brain. So there's a barrier. But however, there are cells, leukocytes, macrophages. These are able to cross the blood-brain barrier, and once infected, they can transmit the virus into the central nervous system or the brain. Particularly, I think we'll refer to this later, that the olfactory bulb is, as I said, it's the nerve that sits right above your nose. That is one of the common ways with which the virus can go to deeper parts of the brain, like the brainstem and the thalamus. But also, we all have to remember that the cytokine storm that I referred to, can lead to disrupt the blood-brain barrier. And also, this is a systemic infection or systemic inflammation or response to the virus, and therefore it can lead to neuronal death. In the elderly, and I'll refer to this point a bit later, that COVID-19 may accelerate neurodegenerative illness, like diseases like Alzheimer's and so on. So one of the commonest presentations, I think physicians and other people may have seen this, and particularly those that are at the front line, is a condition that we call delirium. So this is a state of confusion, and it brings a lot of fights between psychiatrists and physicians. Is it psychosis or is it confusion? So it's in many patients who present to casualties, but also in patients that are admitted. It's a very, very common syndrome, and often it can present without the typical symptoms of COVID-19, that is, fever and respiratory symptoms. So delirium, a state of confusion, that is alternating between a normal kind of mental state and confusion that fluctuates, should give a hint that you need to be thinking of delirium. And this may be related to what the virus does to the brain, but also it may be related to the end product of the cytokine storm, the systemic immune response to the body. Patients who are ventilated for a long period of time may experience or are at risk of developing delirium, but also as patients that may result from problems that may result from respiratory failure, respiratory acidosis and so on. Those are some of the risk factors. So typically, these patients would be very confused. They won't know where they are. They'll be disorientated, particularly to time and date, and often they may not know where they are. And aggression is not uncommon in some instances, and this is when physicians would be calling us to say, aggression means this person has got psychiatric illness and you must come take him and lock him up in your wards. What is also, I think members of the public must be aware that, particularly for patients who are isolating on their own, that, because this is a sudden onset and rapid deterioration is not uncommon with COVID-19, we need to be aware that we need, if patients we know of our family members and so on who are who are isolating and we are keeping our distance for our safety, we have to put in mechanisms to check on them so that should things deteriorate, we are able to seek help as soon as possible. For those interested, the treatment is a very, very low dose antipsychotic medication. If in younger patients, you may use haloperidol 0.25 up to 0.5 milligram. In elderly patients, newer antipsychotics may be an option. But also what is important is that you need to treat the cause or correct metabolic deficits. So if the renal function is impaired, if there is co-occurring infections, treat those to maximize response. One of the most common symptom is smell impairment, but at times this co-occur with taste. But in many patients, it's often the smell that goes first, and then the taste disappears. So it can, in some reports, they say up to 90% of the cases, but this seems to be common in many patients. Females are more likely to experience this than males. The gross nose examination is normal. So these patients may not even have rhinorrhea or even runny nose or swollen nose or blocked nose that you can see. So it is hypothesized that because the nerves that are involved in conduction of smell, that takes the sense of smell from the nose to the brain, maybe are directly infected by the virus or disrupted by the virus. This kind of disrupts, the conduction of smell. So it disrupts the normal functioning of the olfactory, or which is the nerves that are involved in transmission of the sense of smell from the nose up to the brain to be able to tell you what you're smelling. But also, if with inflammation of the nerves, when the nerves get kind of injured due to inflammatory response, they get to hyperperfuse. So you have a situation where there's reduced blood supply of the olfactory bulbs of the nerves that are responsible for smell, and that leads to dysfunction. And that is why in some patients, the smell the sense of smell may take a little bit longer for recovery, particularly in some reports, they say up to 8 months to recover, and there's no specific intervention in these kinds of patients. So seizures, so these are fits or kinds of, epileptic kinds of seizures. So new onset seizures are rare. So it's very uncommon to have patients who just have seizures, new onset seizures related to COVID-19. When it occurs, it's often patients who may have hypoxic injury, who may have metabolic imbalances, or as a result of encephalitis, so as a result of the swollen brain resulting from the virus. But it is important, I think, for those who are treating patients with epilepsy to remember that some patients with epilepsy who may contract the virus may have reduced seizure threshold. So you need to keep an eye on those patients. So if patients would have been controlled, or if patients would have been controlled on a certain level or amount of anticonvulsive medication, you need to be aware that keep an eye on those patients, because the infection, particularly during the active phase of the infection, those patients may have reduced their seizure threshold. What also has been reported is what we call just some jerky movements, or what myoclonus. So there will be particularly on the face. So that often happens post-infection. So there's a bit of a noise. I'm not sure if it's just myself, maybe somebody's not mute. It's a bit annoying to the ears. Thank you. So there's what we call myoclonus, or jerky movements, or abnormal movements, particularly around the face. Those often are post-infectious. So this would be, patients that might be out of isolation post the 14 or 20 days. They may have those, and those are said to be related to the fact that the virus may have disrupted the brainstem. And on the MRI and CSF, you may find that there is no abnormalities. What is also important is that in patients with epilepsy, we need to consider, drug-to-drug interactions. So when you are treating patients who have had epilepsy before the COVID infection, you need to remember that when you are making decisions about treatment of COVID, that you remember that, make a decision about the drug-to-drug interactions as related to what we call the P450 system. So some of the medications that you might give may reduce the levels of epilepsy treatment and leading to seizures, or they may increase the levels of epilepsy drugs in the blood, leading to toxicity. So there's a bit of a noise, and it's very disrupting. I don't know if colleagues can just mute, please.
I see it on a mute.
Can you hear me? Okay, so the other important presentation, I think, which all of us should be aware of, is stroke or cardiovascular accident. So what essentially happens is that your blood get thicker, and your blood vessels are, it kind of, blood vessels, essentially the pipes that transport blood to the parts of the brain, those get disrupted, and therefore you end up with a situation where there is diminished or decreased blood supply to essential parts of the body. And that is how stroke happens in these patients. It is more common in males more than females. And also what is important is that there aren't any prior conditions that would say person A or B is more likely to have a stroke than the other person. And therefore, it is important to always be aware that this can occur at any stage of the illness. Also, there's no differentiation by age. It can happen even in younger patients. What is important is that the condition where the blood clots more than usual, that is often how younger patients would present with the stroke, much more than with patients who may have had hemorrhagic infarcts compared to the younger patients. Just as an indicator that, if you have low platelets, so platelets are those kinds of blood cells that are help us to not bleed, and high D dimers, so this would be the end product of kind of damage to the blood vessels. So those, if you have high D dimers and low platelets, you need to look for a vascular event, and it could be anyway. It could be a deep vein thrombosis, it could be the heart, but also don't forget to look in the brain, because in these kinds of patients, early intervention is much more important than waiting for the stroke to occur. When the stroke occurs, often in up to 90% of these patients, death is the outcome. So memory loss is one of the common presentation. This is a case of a young lady who was referred to us, a 23-year-old college student, previously well, had very mild COVID infection, lost mom, dad, and siblings survived, but presented to us otherwise well, no any complaints, but was struggling to remember. So she would know what happened in 1994 when she was born, when the birthdays of family members were, but she struggled to form new memories. So she would forget the conversation you had with her in the morning. She would forget, if you tell her this is the medication that I'm giving you, you ask her later, she would have forgotten those. So she struggled to form new memory. So for those in psychiatry, it's what we call anterograde memory. So we investigated them. There was actually nothing abnormal with her. We did a CT scan, which was normal, but I would encourage those that are at in the private sector, where possible, consider an MRI. It's probably better an investigation tool for these patients than a CT scan. So the CT scan, it was not really helpful, and we didn't have an MRI facility available to us. So I would, if any young, particularly in younger patients presenting with memory loss, consider an MRI. So we kept on low dose citalopram. We are giving her psychological support. We are seeing her monthly. So this is the second month now, and the memory problems are much the same. She's still struggling, and she has not been able to return to college. We don't know. She asked me every other month when she comes to see me, will it get better? How long will it take? And the answer is that we don't know. I have, but the noise is really annoying. It's extremely annoying. Okay, so I have never said so many I don't knows with this virus, like I've said in the 15 years of my career. So I don't know what the outcome would be in this young patient, but we'll try and keep on support as best as we can, and we will see how far it goes. What is important with memory loss is that the inflammatory cytokines and the hypoxia are often the risk factors. But as you can see in our patient, it was an uncomplicated mild COVID-19 patient. And it appears that these patients also can have sustained cognitive deficits. But I think also for clinicians, it is important to remember that some of the cognitive deficits will only become apparent if you test them. So if you are not going to test the attention, you test the concentration, you test the memory, you test the executive function, you may miss some of these patients. It is also important to remember that memory problems are not uncommon with coronaviruses. Memory problems are not uncommon with coronaviruses. With the previous coronavirus pandemic, it was reported that 1 in 5 cases, people reported memory problems. It is also important, as I said, to remember that the memory loss may be accompanied by dys-executive symptoms. So these patients will struggle with planning, would struggle, just simply to organize their lives. And these impairments may account for poor occupational and functional outcomes, as you can see in our patient who has not been able to return to work. In the elderly, COVID-19 may worsen cognitive impairment. So if you have patients with Alzheimer's dementia, you may have a worsening of symptoms compared to other people who may not have contracted COVID-19. As I said, like with the patient we are treating, we really don't know what the consequences of memory loss are. But there are reports that are suggesting that maybe this is a group of patients who sooner or later we're going to develop some kind of neurodegenerative disease like Alzheimer's dementia, but it's still to be seen. So this is one case I think that probably I'll take for it will stay with me for some time. This was a 58. It's about. I want to just drive home about stigma that this was a 58-year-old teacher with a mildly raised BMI and hypertension, was admitted to a private facility with severe COVID symptoms, but did not require a ventilation. But as a result of physical limitations post-discharge from hospital, required some prolonged period at home for recovery. She presented to us with severe symptoms of depression and anxiety. But at the center of her worry was that when she returned to work, she went to a classroom. She was late on the day, and she went directly to the classroom. And as she put her bag down, the learners in the class walked out. Everybody walked out, and she went to the staff room to report what has happened. All her peers or the fellow teachers walked out. Even the principal did not want to meet with her. And she was months post the acute phase of the illness. But this was during the first wave. Maybe people did not know enough, but that is what led her to an episode of severe depression and anxiety, and she has still not fully recovered. Psychosis, so this is a state of madness. That's what it essentially means. The people who are with history of childhood trauma and prolonged periods of sustained elevated levels of stress, those are the ones that are more susceptible to COVID-19 related brief psychosis. So when it occurs, it's often brief episodes with a alert level of consciousness compared to patients with delirium. So one of the differentiating features in psychosis is that patients know where they are, they are orientated to time and place, and so the key features in psychosis related to COVID-19 is that these patients become paranoid, and it can even be paranoia about the disease itself. They have disorganized thoughts, and some of them even hear voices. What would be of interest to psychiatric registrars who are here is that high level of interleukin 6 correlate with the occurrence of psychosis. And this is the similar finding that we find in cerebrospinal fluid. So when we tap behind your spine to get some water that cushions your brain, we can find some of this there in some patients with schizophrenia. So the post-infection psychosis is not common. So this means that you are past the acute phase of the illness, and subsequently your body has developed antibodies, and those antibodies themselves could trigger an acute psychotic episode. These patients, we advocate that they be treated with risperidone and risperidone or olanzapine, and you need to treat for at least 1 month after symptom resolution. So depression is very common. It may worsen pre-existing symptoms. It may result from the direct and indirect associations. So the direct would mean what the virus does to the central nervous system, that is the brain and the spinal cord, the autoimmune response, but also it may be as a direct impact of loss of function, loss of work, that all those psychosocial factors that may lead to depression. But also depression may be a consequence of complicated or unresolved bereavement, and commonly presents with a depressed mood, irritability, chronic or long-standing tiredness, and disrupted sleep pattern. What is important, I think, is that for those patients who may have had some kind of long-term physical deficits, if in those patients, when you have depression, you have to remember that it might be a risk factor for suicide. Anxiety symptoms may co-occur with the symptoms of depression, and the symptoms account for a significant post-infection burden. So this is one of the reasons many patients are struggling to return to their pre-morbid level of functioning, meaning the level of functioning before they contracted the virus. Psychotherapy is the mainstay of treatment. Where possible, consider antidepressants like citalopram or escitalopram, but in some patients you may consider mirtazapine. So Post-traumatic stress disorder is one of the last, my second last slide. What is important here is that if you have had in the green, if you have pre-existing post-traumatic stress, it means that you have elevated levels of cortisols for a prolonged period of time. That leads to some kind of immunosuppression, and you are more susceptible to, should you contract COVID-19, you're more susceptible to severe illness or poor immune response to COVID-19. And then you get the infection. That just becomes a vicious cycle because the infection itself, directly or indirectly, adds to the burden of the post-traumatic stress. And this are seen often in patients who have been admitted to ICU, particularly those that have been ventilated, may develop new symptoms of post-traumatic stress, either related to the trauma of having been ventilated, the trauma of mere admission to ICU units. But also what we are seeing is the fear of reinfection. We have had patients that who come to the clinic who have been infected, but they have persistent fear that they will be reinfected, and that triggers significant anxiety that can be very, very impairing. But also we need to remember that in some patients, the coronavirus or the COVID-19 may trigger memories of the old trauma, leading to an acute kind of post-traumatic stress disorder. So you've had a traumatic event that have occurred years ago, you have forgotten about it, you get coronavirus, it triggers those memories, and you have an acute response to those old memories of traumatic events that have happened in your life. And this is similar to what we see often in patients with HIV. So in conclusion, this is unprecedented in medicine. I think not any of us has seen something like this, and we need to remember that the effects on individuals is different. So no one person is affected by the virus in the same way, but also the impact will be very extensive for a lot of us in a different way. And for many people, the impact of the pandemic will be long-term. One thing that we probably have to speak about at some point is the mental health burden in healthcare workers. We are seeing our reports of from Italy of post-traumatic stress symptoms from mortuary workers. So I would imagine, patients, healthcare workers in ICUs, in high care wards, may have difficulties of mental health of one kind or the other. Also, something that we speak less about is the psychological effects of quarantine and lockdowns. So, you have, for example, dysfunctional family units. Now you have all these people having to live and tolerate each other for prolonged periods of time. Triggers, anxiety for some, and aggression and violence in others. And even the patients who may have survived with mild and severe illness, many of them will have one or other long-term problem that will struggle with resulting from this virus. The second last important part that I want to speak about is stigma, that it results from myths and lack of information, but also I think the shame that come from other people in terms of looking at those that may have been diagnosed with the coronavirus. And I think we all need to do more in terms of stigma. The last bit, which I think probably deserves a talk on its own, is the issue of the vaccine. I think all of us have a duty to encourage every other person, to take the vaccine when it's available. I do not want to go into detail about it, but the vaccines that are available are safe, and we need to make sure that we encourage everybody to do so. The second point that I just want to talk about in the vaccine is that members of the public need to remember, and clinicians need to remember that with the coronavirus, you don't really need a vaccine that is 100% efficacy. You're not trying to prevent people from not getting the virus. You're in the beginning, you are saying that you're preventing long-term consequences, such as people getting on the ventilator, people getting cytokine storm, which may result in long-term problems. So it's unlike in diseases like polio, where you need a higher efficacy to 100% prevent the illness. So what we are trying, if you, even with 50 to 60, 70% of efficacy, many of us should be able to develop some immunity that will be able to protect, particularly, how we respond to the virus. So we need to reduce it to the level of the normal flu. And that is one of the ways that we can get there. And I hope at some point we can get those who know a little bit more about the vaccine to talk to us about it. Thank you very much.
Right. Thank you very much, Dr. Patladira. You gave us breadth and depth on the subject. And if I just have to summarize, basically, when you have recovered from COVID-19, maybe you had a mild respiratory illness or it was just a mild illness, it does not mean it's all okay. Many people may present with neurological or psychiatric problems, relating to the infection. But I don't want to, add any more words that will distort the message that you gave. Now, let's just take quick questions that have been posed by the people. There are some questions that I see here. One is from Wayne Gordon. The direct effects of the virus aside, how has mental health been affected during the lockdown? Has there been a rise in suicide? I think that's the first question. I'll give you 3 questions, Doc. So has there been a rise in suicides? The second one is from Elzima Arhoff. What is the incidence of post-traumatic stress in healthcare workers, those who did not contract COVID-19 during the pandemic, meaning those who are just, as a result of exposure at the workplace, but they did not really get COVID-19. The third one is from Jonathan Cupido. Does the treatment regime for those who suffer from substance use disorder differ from others? And then another question from the same person, Jonathan Cupido. What are the common psychosomatic symptoms experienced by COVID-19 patients? So if you can just try and do those questions, answer those questions, Doc. Thank you very much.
Thank you. I maybe to start with the second question. As I said, I haven't seen anything that speaks to post-traumatic stress in healthcare workers, but what I have seen is reports of full-blown post-traumatic stress syndromes in mortuary workers in Italy. So these are patients or mortuary workers who probably have to collect bodies, prepare them for burial, and so on. Those patients, those people have been reported to have post-traumatic stress. So I haven't seen anything that relates to healthcare workers. I would assume in this case it would be, doctors and nurses in high care and ICUs. I wouldn't say there has been an increase in suicide. However, I think there has been an increase in distress, and therefore what we see is that even patients who have been doing well for a long time on medication, they've become much more vulnerable. So we need to see them more frequently. We need to adjust the medication. We need to admit some of them as a result of the distress that come with the pandemic. As it relates to substance abuse, it will depend on what kind of substance use or regimen you are taking. But I would imagine the important issue would be you need to think about the drug-to-drug interactions. Bear in mind that COVID-19 is a systemic illness. Thank you.
All right. Can I maybe just quickly add, Doc, something I came across on this thing about the frontline workers. On the same article that was from King's College London, they said the COVID trauma response working group study, they carried out a midsummer study amongst UK frontline health and social care staff. And they reported that amongst the 1,000 people who were surveyed, 47% met the criteria for the diagnosis of anxiety, 47% for depression, and 22% for post-traumatic stress disorder. And the majority of those 1,000 people had at least one of these disorders, that is either anxiety, depression, or PTSD. So despite all the many efforts the UK National Health Service and the care sector to support staff, most workers in these settings have recently had clear-cut mental health problems. So I thought maybe it does touch on this matter, although it is not, within South Africa. All right, is there any other question for Doc? Okay, but anyway, if there are any questions that come through, Doc is still going to be part of us. He can answer those questions. Thank you very much, Doc. Now I am going to then call upon, the speaker of the city of Joburg, the biggest city in the continent, somebody who is active in civic education, Madam Nongceba Mulwele, to just give us from a community perspective, what are they picking up, as the municipality. They've got 84 clinics throughout, the city that are doing primary health care. There's a lot of secondary and tertiary hospitals in and around Joburg. So she just wants to give us a sense, as healthcare people, are we doing enough? Is there some things that we're supposed to do or do better? And then as soon as she is done, then we'll go to Usiskosi Jian. Can people on YouTube also send any questions so that we can read them here? So, speaker, can you switch on your camera and talk to us quickly?
Thank you very much. Thank you very much, and good evening to all the listeners. Good evening to you, our host, Bele, Dr. Afundile Nyathi, our panelists, Ms. Kosi Jiane and Dr. Lebogang Patladira. Good evening. Our viewers on all the online platforms, good evening. As introduced, my name is Councillor Nongceba Mulwele, the Speaker of Council in the city of Johannesburg. Doc, in relation to civic education, I must say that we are starting this year 2021 with a bang. As you have already said, I am very pleased to announce that we are forging a partnership with local community radio stations, Josie FM, Alex and Eldos FM, and I would like to thank them for broadcasting this very important discussion with Dr. Afundile Nyathi, who is a medical doctor by profession, our partner in civic education in the city of Johannesburg. and the host of tonight's dialogue through this webinar and this digital platform. Yes, Dr. Patladira, COVID-19 has indeed negatively affected the mental state of our communities. I went to your presentation and I was actually saying, this is what we're experiencing at a ground level. I believe we are all hoping, or we were all hoping for a better 2021, but we find ourselves still under level 3 lockdown regulations. In the past few weeks, we saw the numbers rocketing to unprecedented proportions. Whilst the cases are steadily dropping almost every day for the past, while I have been waking up to constant messages of rest in peace, condolences on every front, and that on its own is traumatic. Some of us, sometimes you are even afraid even to switch on your phone in the morning because you are going to be confronted with these messages. So the numbers have turned into names. The names become synonymous with faces. The faces are of people that we know, and in most instances, the faces are of people that we love. COVID-19 has really exposed the brutal inequalities of our country, with our communities in the less privileged areas being most affected. Once this pandemic affects all segments of the population, I would argue that it has been especially brutal to vulnerable groups of our society. As local government, our experience on the ground is that the most affected are the most impoverished, are the elderly, are young people, are women, business, and entrepreneurs. Many small businesses have not survived the lockdown. Young people who were unemployed before lockdown are slowly losing hope due to the severe economic impact of the lockdown. The impact on women, particularly poor women, cannot be ignored. The impact of unemployment on poor Black women, who are already the highest unemployed in our country, is severe. Women across class strata experience increased domestic and childcare burdens, as well as increases in domestic violence. You spoke about it, Dr. Patladira. In 2020, we've had police ministry indicating that incidents of rape had increased by about 706 cases compared to the same time in the previous year, and police detected about 1,638 more sexual offenses than the previous year. Gender-based violence is described as South Africa's second pandemic. There are instances where our counselors have had to intervene in gender-based violence cases, and women are in continuous state of anxiety and fear. Furthermore, women are angry because they are tired of having to live in a state of fear where they must fear the virus, they must fear losing their jobs, and also fear their own partners. COVID-19 has highlighted long-standing social fractures in our society. In reality, it is difficult for people in vulnerable communities to practice social distancing in crowded living conditions. In the informal settlements, it is difficult to practice hand washing with limited water. It is difficult here to down regulations when you are hungry. And all that is on your mind is to go on, fend yourself just to survive. There are major psychological and social consequences on the ground of loss of employment and the broader economic crisis caused by the lockdown. You have mentioned some of these consequences. There is a fear of infection. You know, there are questions if you are infected, or even if you are not yet infected, you ask yourself, will I get the virus? If I do get the virus, will I survive? If you survive, what are the consequences, the post-consequences of having been infected? People who are overweight or have diabetes are particularly fearful. With a mere sneeze or a cough, and already one is worried about whether it is COVID. So, sesaba nokukhwehlela, sesaba nokuthimula, because then you think, oh, it means I am infected. So even a flu now evokes feelings of fear, and that is trauma, you know, on its own. It has changed our ways of culture and tradition as we know it. The way we used to bury is no longer the same, and people find it hard to get closure. We can no longer view the body, or in some instances, wash the body for those who follow these practices and other rituals and practices that come with burials, as we know, especially in our communities. Furthermore, the information overload and conspiracy theories on 5G and the coming vaccine do not make the task of inspiring hope in our communities any easier. I know, Doc, you said that is a topic for another day that needs to be unpacked. I can go on and on, but let me round this up because of time by saying we are all in it together. Whether it is an underprivileged community or a gated suburb, we are all in it together. We are all mentally vulnerable at the moment, and our population's mental health has received little statistical attention locally. There is a need for government and healthcare bodies to strengthen partnerships as it relates to the advancement of the mental well-being of South Africans, especially during the pandemic. Let us sit around the table, all of us, starting here in Johannesburg. Let us review all the 86 clinics we have spoken about, Doc, and build a bridge that will allow for the services of psychology so that you not have to do referrals. Let us have psychologists in all our facilities. We as government cannot do it alone. I understand that there is not enough psychologists in our country, but even that needs to be addressed at an institutional level and must be changed at grassroots level by encouraging more young people to get into the space so that we have a greater pool of talent. With that said, I don't want to waste more time. Thank you very much, Doc, for allowing us. And thank you very much for this platform. And I hope that this partnership will have an impact in our communities, especially when it comes to civic education. Dr. Nyati, let me hand back over to you. Thank you very much.
Thank you, Madam Speaker. You know, sometimes we talk amongst ourselves as healthcare professionals and don't always get the perspective from communities. So it was good to just listen to you and you sharing from your point of view, you know, what you are seeing in the communities. Thank you very much. Now I'm going to call upon Siskosi Giane. Can you please unmute yourself, Siskosi? Right, Siskosi is a clinical psychologist, you know, who got her MA, her master's cum laude. I always respect people who get degrees cum laude. And then she's now a PhD candidate with UJ. You know, that's on the academic side. But she does a lot of work in the media space as a resident psychologist within radio stations. She is a resident psychologist for Weekend Breakfast on 702. You know, She listens to me on Saturdays as a resident doctor. On Sundays, I listen to her. But also she is a content producer on matters of, emotional or mental health, radio, TV. She also does workshops, facilitates self-leadership, issues. So she's quite broad. Now, she is not going to use a formal presentation. She prefers an engagement, so I'm going to ask people to send questions via the Q&A to her about anything you want to ask her about relating to, mental health, from a psychological perspective. But to kickstart the discussion, Siskosi, a lot of studies have been done in different countries, since this COVID-19 pandemic started. I remember a study that was done in China, late January, beginning of February last year, where they were looking at the psychological impact of the pandemic on the population. And one of the things that they picked up was that, the psychological impact on, the people who were in that study was moderate to severe. All right, moderate to severe, with a lot of anxiety symptoms, with a lot of depressive symptoms. And this was still at the early stages of the pandemic. There are other studies now that have gone further. So what I want to find at the beginning is, knowing that there is this pandemic that has killed so many people in other countries. We've seen what was happening in Italy, and we then had our first case here in South Africa on the 5th of March. On that day, it became real to South Africans. Now, can you just help us to just understand the psychological impact of that kind of thing now getting to our shores, even before, we've had lots of, cases coming up?
Okay. So good evening, Dr. Nyati and Dr. Patladira, and the community that is taking the time to join us this evening. So thank you for the question. I think, if we just cast our minds back to the beginning of last year, and I think that everybody will agree with me that there was a time when we had the luxury of thinking, not us. Like, if you think just geographically, where China is and where we are, it is literally worlds apart. And therefore, for a long time, we had this sense of comfort and this sense of safety that something was going to mitigate this before it gets to us at the tail end of the crocodile of Africa, So we were assured on many levels that, we were not going to it wasn't going to get to us. And therefore, for a lot of us, while we saw it in the news, for a lot of us, it was business as usual, right? And I think if we cast our minds back to when we had the first person that was confirmed to have been infected, it changed our world, right? And so suddenly, at that point, we were, in reality, part of the global community, whereas we had thought of ourselves as on some level, immune to what's going to happen to the rest of the world. But we also found that there was still a lot of denialism. And unfortunately, I have to say, even up to this day, we still experience a lot of denialism, right? And incidentally, I had a client who is from Soweto, telling me, Uguti, Elokshini, it's pretty much business as usual. Everything is going on. People still don't take this seriously. And even at taxis, if you wear it, you don't, it doesn't matter. It's up to you to decide whether to wear it or not. Nobody's going to make it compulsory. Even drivers don't wear the masks. And it's difficult to talk about social distance in a taxi. So there are competing priorities in that sense. But equally important that people still continue to hold on to narratives of the world as they have known it, and people are not migrating to the world as it is, right? So we have that struggle going on, let alone the fact that we have in the bigger space of science, the people that we generally look up to for answers, we have competing truths even within that space. So there is no one clear guiding narrative or discourse that people can follow. And so we are just finding ourselves flung in different directions. And the question becomes, you know, what do we do? Which truth do we follow, right? When you have people who are scientists and all of them boasting various degrees of qualifications and so on, even they themselves don't agree amongst themselves. It then leaves us, the common people, in a very difficult position. And on some level, the denialism is understandable, given that there is no one clear guiding discourse. And we also have this gift and burden and curse of the fact that if you look at how life was previously, you know, we were sort of isolated in relation to the world being in the palm of our hands at this point. Everybody owns the world in the palm of their hands through their cell phone. So we all have access to information. It is very difficult to filter things out. And so we are constantly bombarded with various types of messaging around this. And people are really like, we are headless chickens, and we are really thrust at the center of all these discourses going on around us. And therefore, you can imagine the weight that it places on us psychologically. You know, what do I do, right? And I think logic, and again, I'm saying this advisedly, would suggest that, especially now, because if you look at the progression of things, we have had the luxury of denialism, in that there was a time when this was at a distance from us. And I think the speaker, you know, spoke to it very well in terms of saying, and I know that this is real for all of us because we hear this in everybody's conversation, that this has moved from a conversation about, you know, the COVIDometer, when we were just all of us clicking on our phones and just watching those numbers go, right? It was just digital, it was just numbers. The people were far and few in between. But we are seeing that picture changing ever so quickly, to the point that as we sit here, I'm sure that all the people on this call, I am willing to put my head on the block, that we all know somebody, we know them by name now. We know who they are related to, if not to ourselves. We know who they are related to. So it is much more palpable. The pulse of this is real, right? And therefore it calls on us to sober up, individually and collectively, to sober up. And I'm of this opinion, and I'll stop here before I ramble on, because I can ramble on if you give me the time. I just want to say this, that logic should dictate to us that even as I sit here, and it may be foolish of me to say so, but I admit that there's a level at which I don't know what's going on here. I really don't know. I stand and I take this one view and I question it, and I don't have definite answers. And I stand on this side of things and I take that view and I don't have definite answers. But I think the one thing is that in all these conspiracies, and you will call them a conspiracy if you don't believe in it, but for those that do believe in it, it's real for them. So we have all these realities that are competing. The important thing, however, is you have to be alive to participate in those discussions. So whether you believe it or not, you have a responsibility to make sure that you protect yourself, because the reality is that the virus doesn't care about your beliefs. It doesn't care about whether you think you're a saint or a sinner and so on. The virus acts in a way, in a very determined way that viruses behave. And therefore, whether you believe or not is really immaterial. Logic should say to us that the mind field should be our first port of call as a minefield, in that we can then have discussions about whatever we want, be indulgent. But after, there's different phases in this. We have to make a judgment call that says we have to prioritize, and survival has to be top of mind. Right.
Thank you. There's another question that has come through from the Q&A section. This one is from Nodumo Mchemla. That's actually my big sister. I'm happy that she has joined. My big sister lost her husband on the 30th of December. That's just a few weeks ago. So she's posing a question. Doesn't the fact that COVID-19 diagnosed patients are isolated worsen their condition? For example, a spouse not being allowed to visit to assist with feeding, psychological support, etc., except to fetch them as corpse. So I think this one is talking to a situation of somebody who has had a soulmate being admitted, obviously no ability to visit the soulmate at the hospital, and only seeing him when he had to fetch him or identify him as a corpse. So can you maybe just talk about that? And maybe on that, because that's my family, within another 3 days, another family member, was also, dead. So this thing of having multiple people from the same family, how do you deal with that kind of grief? So maybe I can just combine those as one question.
Yeah. So firstly, my condolences to you, Sisi. I cannot even begin to imagine the gravity and weight of this experience on you, your immediate family, your children, if you have, but also your family in terms of your brothers and so on, because none of us remain untouched by the impact, or it echoes throughout the family system and the community system. So none of us can remain unaffected, if not infected. So the first thing, I think the question that you speak to is about, at the heart of us as human beings, what defines us as social relational beings is that social connection is important to us. It is what defines, what distinguishes a mammal, which is a social being, from a reptilian being. And there is the infrastructure in the brain that supports that. And therefore, the behaviors that we exhibit, and the reason why we are being so challenged right now with social distancing, is that it goes against the grain of being human, social, relational beings, right? And therefore, the question is very, very true, to say, doesn't that worsen? Doesn't the fact that our loved ones are isolated? I mean, I know of a client who also, and that may also be your experience, the fact that, first of all, that the person was so desperate, to be taken to a hospital, and an ambulance came, and there is so much commotion in getting all that done. She gets to hospital, she's busy with administration, the person was wheeled away, and she never got to see this person again. And so, again, it is just that experience of having someone stolen out of your hands in the physical sense, and therefore later, and equally later, stolen out of your life. And the magnitude of that is unimaginable. And equally true that, yes, under normal circumstances, it makes sense that actually isolating people from loved ones who could support them, who could speak to them, who could comfort them, has an aggravating effect on them. And I know, we know this from studies of premature babies, for example, that when they are kept in the incubator without human touch, they don't grow and thrive as much. And therefore, hence, it has become common practice to take babies out of these incubators and put them, connect them, and tie them to their mothers for as much time as they can, because we know that as human beings, we thrive through that connection. Physically, it reconnects us to this being that we have been connected to pre-birth, but also psychologically, the effect is that it gives us psychological safety and emotional safety, the sense that I am loved, I am cared for, I matter, right? My condition, you know, is important to other people. My presence and my absence is important to other people. And that has a healing effect on us. In this situation, however, we have two competing priorities, and that makes it so difficult, because we have, on the one hand, the cure fraternity, which is the medical fraternity, which seeks to cure symptoms, the physical body of the symptoms that are ravaging the body at that time. And we also then have a competing need for the healing fraternity, because we say in psychology, we don't cure, we heal, which is about restoring to wholeness, to relationality, to our sense of self, who we are, our relationships with other people. And so at this point in time, these two are at a collision course, and it is just too risky, because we cannot attend to the psychological if the physiological is not taken care of. So in your case, for example, if you were allowed into that ward, a ward that has people that are equally sick, it puts you in a vulnerable state. And therefore, you know, physical safety becomes the first priority port of call in terms of prioritizing what needs to happen. And it is an unfortunate reality of this reality that we are in, that we are having to be at this knife edge and make very critical decisions which have absolute psychological and emotional ramifications, which we will have to deal with. And hence the question was asked about PTSD. I want to say that we are not dealing so much with PTSD as much as we are dealing with CTSD, which is continuous traumatic stress. Because if you're talking about people at the front lines, it is not post, it is all the time, it is ongoing. And so therefore the grief, the levels of grief that we are talking about is compounded grief, rather than, you know, just the normal everyday life as we have known it previously. And therefore it just heightens the need for self-care, the need for reaching out, even though we're talking about physical distance. And I think we need to re-articulate this phrase, because we've just gone into the social space and said social distance, right? And it presents us with a dilemma, because essentially what we are talking about is more about physical distance, but ensuring as much as possible that there is social, emotional, and psychological connection. So use all the resources that we have, save physical closeness, to connect with each other and support each other the best way that we can.
Yeah. All right. Then there's another question. And this question, I'm just trying to, right. It's about how do I deal with anxiety during this COVID-19 era? We know that because there's a lot of uncertainty, you know, what's going to happen tomorrow, how many phases of this pandemic are going to be coming, and will I survive each of these phases and all of those things. And some people even start to experience symptoms, you know, just because they're worrying about them. So when you've got those thoughts that are fixed in your mind, you know, that are triggered by the threats, you know, relating to this pandemic, how do you deal with that?
Yeah. So it is normal. We are bombarded, mentally bombarded at this time. And it is overwhelming, the kind of, we are living with this fear. So we have an enemy that we can't point to. It's invisible, it is omnipresent, and then we hear, just when we think we've got it figured out, it mutates into something else. And so it is logical that we are thrown, right? And we are experiencing untold levels of anxiety. So it is understandable. Unfortunately, the depth of the uncertainty calls on us to dig ever so much deeper within, because it is the mind field that's going to be our mine field that we have to mine ourselves out of. And so we need to remind and remember ourselves. Remember means to put things together where they belong. So we need to get perspective. We need to get a handle on this, because otherwise we're going to be victims that are just going to spiral helplessly into this situation. And I know I'm asking a lot of ourselves, including me. I know that even as I say this, it doesn't ring, soundly to ask us of that, but that is exactly what is required. It is that paradox, because we are living in unusual time at the knife edge of things. So important things. Dr. Patladira spoke earlier on about the cure side, the medical regimen side. And this is the thing that he also spoke to, that this situation, as much as it is a collective human social experience of global proportions, it will meet us individually in our own individuated selves. And so each one of us, it will heighten, it will have a knock-on effect on the pre-existing self that we were. So if we were anxious on some level, and already were perhaps on some treatment process or some level of vulnerability, of psychological and emotional vulnerability, it's going to build on that. And therefore it becomes so much more important that we pay particular attention to self-care in terms of both the medical side of things, having ourselves checked out in the physical body to make sure that we maximize the health of the body. There's medical help that we may need to seek, but equally important, things that we can do ourselves. And we have to be grateful that we are at a level at this point in time where we are not at level 5, where we were locked in entirely. We have some freedoms. Let's use those freedoms productively. We have the ability to exercise. And I'm not talking about going to the gym. The whole world is a gym. There's plenty of open spaces for us to walk. That is the cheapest, most effective form of exercise that you can get. What it does to the body is amazing in terms of refueling you, the hormonal, rebalancing of your hormones. It gives you perspective just to be outside of your spaces and locked in. It does wonders for us physically, mentally, and emotionally. So we have to take advantage of all those resources that we have, but also equally important in terms of our mind field is to be able to distinguish between 3 things. What is it that I can control? And I know many a times in these circumstances, it may feel like I don't have a lot within my control. But this is the principle here. It is that even if you can only control 5%, control that 5% 100%. Do the most with that 5%. 100% of that 5% is going to make an exponential, not just an additive difference, an exponential difference. Secondly, it's about what you can control as the first category. That's the most immediate to you. Second is what is it that you can influence. And if you maximize those 2, it begins to erode the gravity of what is outside of our control. So if you just focus on what you can control and on what you can influence, it will help us to mitigate and stave off what we can't control. Let me stop here for now.
Yeah. All right. A related question, maybe this one is more for frontline workers. What coping skills would you recommend for frontline workers to deal with anxiety?
It is so difficult when you are constantly bombarded with the threat of your own vulnerability, plus being exposed to the vulnerability of those who are infected and the morbidity of those people who die, at your hands, in your space, and so on. So I think those people, we are talking about quite a high level of exposure here. And therefore it becomes so much more important. And I know that I was speaking to a friend who is based in Cape Town, who's specializing and saying that, they've been dragged out of their specializations into trauma, which is areas that they've never had to work in before. and they've had to pull out the books and try and learn things that they had moved away from. And so it is, and they have been provided support services. And there was a time when they had the luxury of not using that. But the extent of things now, and I'm hoping that, as the speaker was saying, and I'm trusting, I'm not based in the healthcare system, and maybe Dr. Phatladira can speak to that there has been efforts made to provide people that there has to be some sort of psychological and emotional emptying. And it's important that you verbalize. The problem is that the body keeps the score. The more we keep inside, the body holds on to that and narrates ourselves out of that, because we don't always have the luxury of talking to a professional. But when you get home, to just physically, express that, speak that out of the body, it somewhat mitigates. Get as much rest as we can get. And I know, as I say so, what rest people will ask, and that is also equally true. So we have to take everything that we can, ask for assistance in your family members with things, responsibilities and so on. And, somebody to massage your feet, your back and so on. Whatever little resources or sources of support that we can get, let's maximize that.
All right. There is another question. That is a comment. I'm yet to hear about a mental wellness program that caters for frontline workers during these difficult times. Is there something in the pipeline? So I think you've touched on it a little bit, but maybe not a formal program. But this person is asking, but if people are working for large employers should be putting in place employee assistance programs so that people can be able to access psychosocial support, via those employee assistance programs. But a number of companies in South Africa, medium-sized and small companies, and even some government departments don't have that type of program, which then, leaves people to use their medical aid, and the benefits on the medical aids for accessing these kind of services are usually very thin. But do you want to say something about that, Siskosi?
Well, I think we've pretty much spoken to, and as I say, unfortunately, I'm not in the official public health system and so on, but I am aware, and that colleagues of ours have been talking about, being available to offer support in there's different groups that have been formed, and I know there was conversations about that earlier on when this crisis began to affect frontline workers as much. And as you rightly say, employers are beginning or needing, and this is one of the conversations, because I work actually a lot more in the corporate space than other spaces, where we are having conversations with employers that say, this is an extraordinary circumstance that employees are facing. We need to be so much more conscious around the types of support that employers are giving to their employees, and create zones of care where people feel that they still belong. And importantly, and I know this is not what this question is about, and I think it was touched on earlier on, threats to livelihoods, threats to jobs, threats to incomes, and so it is quite a compounded, stressful time that we are facing at this time. And maybe let me go to Dr. Phatladira in terms of what's happening perhaps in that sector.
Okay, just before Doc, there's somebody who's saying, how do you counsel somebody who has been advised that he or she needs to be admitted because of the severity of their COVID-19 disease, but they have a fixed belief that hospitals are nothing but places for people to die. So therefore they've got fear of death, and because they've got this fear of death, they are refusing basically hospital treatment.
Yeah, talk about a dilemma. So yeah, I think, one of the things that we need to do and I've started to say this on various media platforms that I have opportunity to use, that we need in our families to start talking about death. We need to normalize death. We need to, this is our reality. It cannot be this thing that is lurking in some dark corner. We need to normalize death. We need to make plans for what will happen. What are we going to do? Who has what policies? So that we are not bouncing our head, because I have had so many accounts of people talking about just how families are, embroiled in conflict when somebody has died in the family, because people are butting heads. And this is the worst time for people to be in situations like those. But to come back to this, we have to have conversations allowing the person to bear the unbearable. And so to have the conversation about what it is, we have a responsibility to look after them. And to help them understand that we don't, in our own homes, have the expertise to take care of them and whatever symptoms they're experiencing. But I'm also going to say, and this is quite a bitter pill that I'm asking us to swallow, that on some level, and this is not just related to COVID, COVID has a particularity in the sense that it is a contagious disease, so it puts other people at risk. But we have to also allow people the dignity of choice for how they want to spend their last moments. In this case, it is difficult because we are obliged by virtue of the fact that they are going through a contagious disease. And part of the challenge becomes that, psychologically, they've been affected and there's been psychological fallout, and they don't have the capacity to really process. They themselves are overwhelmed. Somebody has to take responsibility in the family for being the brain of this person and of this situation, to give direction. And sometimes difficult decisions have to be made because this is the nature of the beast. This is the time that we are finding ourselves. We don't have the luxury of comfortable choices and decisions at this time.
Thank you. I think the last one, then we'll go back. There's a few questions that were posed to Dr. Phatlhadira, so I think we'll go and take some of those questions. But there is a question here that says, these social workers, psychologists, and other people within the EAP space are expected to provide support to employees within organizations. But what happens to them? Who cares for the carers? I think that's what the question is about during this time of COVID.
Yeah, this is the perennial question. So even before the COVID, the question has always been, where do you psychologists go? Because you are always listening and carrying the burden of people's problems. Where do you go? So there is something I will loosely refer to as intervision. So psychologists go to other psychologists. So we have to spread this capacity to take each other in and be each other's repository for whatever challenges we are going through. And we are constantly, like a computer, having to reboot ourselves. And part of the skill of any healthcare worker is we have to position ourselves in a way I'd say detached attachment. In other words, we have to be immersed in what's going on with and for the client or the patient, but we also have to be able to extricate ourselves, because if we don't, this is when you're going to suffer from burnout, because you have not been able to detach yourself and you become emotionally invested and in using your energy instead of helping people to find their own strength, to pull themselves through. So it's a very fine balance. But in the EAP programs, those people are themselves responsible for self-care, and organizations then have to make sure that they themselves have a network of people that they go to. And this is just the reality. It just has to circulate, that we can, as we say, a problem shared is a problem halved. Not that we necessarily will take it away at this point in time.
All right. I'm gonna ask you a question, but you can think about how to handle it. Let me go back to Dr. Patladira. Doc, unmute yourself.
Yes.
Right. I forwarded 2 questions to you. It seems like the issue of memory loss or cognitive deficits post-COVID is something that is scaring quite a lot of people. Some are asking, how long does it take, that memory loss to resolve, or at what point do I start to take it seriously, after waiting and hoping that things are gonna get better. And others are even asking, are there any meds that could be taken to try and help with that kind of challenge? Maybe just deal with that just as one question.
Yeah, thank you. So as I said, we don't know how long these memory problems last, as you saw in the case that I presented. But from the reports from China and Italy, they say probably 6 months they should be getting better. So I would say maybe after 6 months, if you haven't had in-depth assessment and investigations, you may need to consider that at that point. There is no specific treatment, like we would in other kind of memory problems. But I know that there are trials around the world to see how we can attend to this. But I would encourage people. In fact, I think everybody should, if you are above 40, you should be taking omega-3 fatty acids. They, in their own, help with, they've got what we call anti-inflammatory properties. So the cytokines don't become a little bit less. So if you are 40, particularly female, you need to consider taking omega-3s routinely. So I would the patients that we treat, we give omega-3 fatty acids and low dose antidepressants, just to contain the anxiety, because they are aware that they can't remember. So to contain the anxiety and the depression that may come as a result of the deficits that related to memory loss, we treat them with that and then just buy time.
Yes. Now, is there any role, Doc, of other healthcare professionals like your OTs in trying to help with some of the, I would say, challenges on the cognitive side, as part of rehab?
Definitely. I think if I think you need a psychiatrist, you need a psychologist, and an occupational therapist to conquer mental health, I think. And particularly those that are returning to work. And I think mainly for education of the employers, but also for adjusting, if you can't remember, adjust your diary, make notes of certain kinds. So an occupational therapist are well qualified to be able to help with those that have to return to work or to return with studies, but also with domestic care. You'd imagine that you take diabetic medication, 30 minutes later you have no clue whether you took medication or not. So they would put in mechanisms to help patients be able to remember as we buy time.
Yeah. All right. No, thanks, Doc. I think, was there another question there that I'd forwarded to you? I don't know if you picked it up. Okay. Whilst you are checking, Doc, I think I copied and pasted 2 on the chat function. On the chat function.
Chat. Okay.
Yes. From me. All right. But Siskosi, the issue of stigma and social stigma and discrimination of people who are, who have COVID or who have recovered from COVID or who are relatives of somebody who may have, COVID or died of COVID. When they get isolated by, members of society, how do they handle something like that?
So there's two sides to it. So on the one hand, what stigma is, it's just an expression of fear, right? So I think the best way to heal people from their fear is understanding. It is simply to understand where they are coming from, to understand that it is understandable that they should be fearful. Because I think if people are not fearful, then they become hyper vigilant, like, I don't care, it's okay, and so on, right? So it's important that we become vigilant at this particular point in time, and therefore to understand it in the context of that, to understand it in the context of people's own vulnerability, or they don't even know what their resilience is. So when, for example, you will have gone through that infection and you will have survived it, but they don't know if it gets to them, whether they would survive it, right? So it is a natural reaction, knee-jerk reaction, instinct, survival mechanism that says, take care of the self, right? And all of us have that, it built in within us, that, the self-preservation gene, as we say, that says, protect yourself. And so to know that people will slowly, as they see, they will come to align their understanding, and like ice, it will slowly melt. So I think I would say understanding is the biggest gift we can give ourselves and people's reactions, that it is normal, anticipated at this point in time, and it too shall pass.
Thank you very much. Thank you very much. We need to wrap up. We were supposed to have just 90 minutes of this webinar. We've gone beyond that. Dr. Patladira, did you manage to see the question that I had forwarded? You please unmute. Please unmute, Doc.
Sorry, I covered most of them. They were on the memory loss.
Okay, lovely, lovely. I think at this point, I must just thank both of you and also our speaker of the city of Joburg for making time. We can never be able to cover everything in one webinar, but I think what one wanted to achieve was to say there is this silent epidemic, or there's this silent pandemic. We're focusing a lot on the physical side of the pandemic. However, this other people, they call it parallel, pandemic. We need to have, more conversations around this. I mean, one of the questions I think I will ask, which is the last one for Usiskosi. Many people who are Black Africans have got certain rituals that they normally perform as part of, as part of a grief process. Now, some of those cannot be performed because they pose a risk of causing infection amongst the family members. Now, that inability to perform those rituals, which were part of their healing or grief process, how does it affect, or what impact do you think it has on their ability to have closure?
So part of the impact of that is what we can loosely refer to as survival guilt. Those that survive the person feel that they have not honored the person in their customary ways. And here lies the word customary. These are things that we are accustomed to. And I think we have to bear one thing in mind, that these rituals and customs, we experience them in the now, and they feel to us in the present time, which is the only time we can live in, as if they have always been like this, and they have not. We talk about social evolution, that customs and rituals never ever develop in isolation. They are always aligned to the time we find ourselves in. A simple example, the fact that it has taken generally so long for people, like a week or two before burials, and in some instances even longer, for people to be buried. It has had a lot to do, for example, with the migrant labor system. When family members, were out working, they needed to send telegrams and so on, communication took longer, and therefore these things were delayed. This is not how it was when people were living in homesteads and people would bury at home before, mortuaries and so on. So there always is social evolution. So let us forgive ourselves. Again, let us be understanding that it is not a choice that we are making. It is a circumstance that is imposed on us. So let us do what we can within the constraints that we find ourselves in, knowing that if we are alive, we can always go back to those things that were not done if we still feel the need to perform them. But also accept that some things will change, we will adjust. That is part of the nature of things. It just always feels like now that we can't do them, it feels like that they have always been this way, and it is not true. So let's go with the times. We will have the luxury of adjusting later on, hopefully.
On that note, thank you very much, Siskosi, for giving us your time. Thank you very much, Dr. Patladira, for enlightening us. I'm sure it's not the last time I come to you guys and ask you, to assist again on some aspect of your area of expertise. But for today, thank you very much. And I also want to say thank you to all the people who managed to log in. We had about 450 people who had registered, but there was some little technical challenge at the beginning. So I think some people gave up before that matter was addressed, but still we had good numbers. So thank you very much. Apologies for taking a little longer than the 90 minutes that we had promised. So I hope each one of you managed to learn something from our speakers, from Dr. Patladira, from Siskosi Giane, and also, perspective from the community, from the speaker of the City of Joburg Council. So with those words, thank you, stay safe, and keep all those non-pharmacological, preventative measures. Please, let's also make sure that we think twice before we attend funerals. They are major super spreaders. Sometimes it's difficult to say, I'm not gonna come to a family funeral, but there are other ways to be able to honor that person, even if it's not now. So on that note, let's just be vigilant. Let's do everything that's within our power to prevent getting infected. Thank you. We appreciate your time.
Good evening to all.
Thank you.